I want to again thank everybody for being here. I want to thank everyone for having invited me to, have the opportunity to come and share and learn from you. And what I thought I would do is put together a probably a talk on GVHD, which a lot of you haven't heard. So I'm going to go back and talk about the past and not as much about the present, because I think we can learn from where we were. And sometimes you'll see that the lessons that we're learning are the same lessons and the same things we were doing a long time ago. So I want to say, when I started this in the business of immunology, I go, there was a time a long, long time ago. In a few words regarding the science of transplant. When I started and went into the laboratory in 1981, we didn't know how a T cell saw the target cell. There was a big question. Was it a one receptor that a T cell, we knew that HLA was involved. Was there one receptor to see HLA and a second receptor to see antigen? Or was it one receptor that was seeing the combination? They didn't know what CD4 and CD8 was. And really, by 1983, the laboratory I was in, one of the people, Alan Krensky, showed that actually CD4 is the HLA class 2 receptor and CD8 is the HLA class 1 receptor. And people started to say, oh, you know what? Adhesion's important. How do cells stick to each other? And at the same time, the group from Tim Springer discovered LFA1, which is lymphocyte functional antigen 1, the first one. And it turned out that it didn't have a necessary an activation, but it made cells stick. The lymphocyte could wander through the bloodstream, but when it saw its target cell, how does it get there? Well, it has to stick. And so we learned about adhesion. So we're rapidly learning the biology of interaction. It's important to recognize that at the same time, people were sequencing genes and everyone was predicting different structures of what HLA would look like. But it turned out that they ultimately proved that there's an interdependence of the outer domain, and I'll show why. This is an important paper. This came from the laboratory that I worked in. This is the first demonstration of basically a one receptor model. And Avi Ben-Nun basically made multiple T cell clones, and they were restricted. They were identified as they see antigen and they see HLA-DR. Turns out he then screened it on self with influenza, and he showed that this was the answer. Oh, this may be a little confusing, that allo, what is allo? Allo is MHC, the histocompatibility antigen, and something else, a peptide. MHC plus X is allo. This basically started to open up understanding how T cells saw each other, saw disease. And so in 1987, two papers came back to back. They crystallized HLA. And this is what the crystal structure of HLA class 1 looks like. And what it is there's two areas, two different genetic areas. They come together and they make a scoop. Well, if you over here, it won't be function. Here, it won't be function. They come together and you make a pocket. Turns out the T cell sees the edge of the pocket, but inside the pocket, there was this little red stuff. Everyone thought that was garbage, but that's the key to allo. That is internal self-peptide. And it turned out in this case, it was an Epstein-Barr virus peptide that was in there because came from an Epstein-Barr virus line. Anyways, a little bit of science, but within basically 5 years, the world of immunology started to emerge. This was work that we did, which also showed that if you have a patient and they don't have graft versus host disease, they don't have graft versus host, right? But if you go and take blood from that person and then isolate it away from the rest of the cells and target against antigen, target against allo, there always will be a response in the laboratory. Every single patient we transplant at a laboratory level, even if they don't have a skin reaction, don't have diarrhea, you can show that there are cells in circulation. If you take them out, they'll react. They will see foreign and they'll want to react. It turns out the immunology, there's a network to suppress the signal. And that network is what's called tolerance. So when you see a patient and you think, oh, they don't have GVHD, they have cells that are reacting and are definitely capable of causing GVHD. It's just that they're suppressed. And I think I had a patient once, 9 years after transplant, never had graft versus host that we know of. But she came in, or she got sent to me because she had dry eyes, dry mouth, and food was sticking. What's that diagnosis? Chronic graft versus host disease. So for 9 years, absolutely no detection, no anything. The cells are there. Something needs to trigger them, but every single patient has GVHD causing cells, even if you don't see it. So even if you don't see it, we know immunologically there is a graft versus host response. Now, a couple of these slides are sort of I had the opportunity to have Dr. Reiner Storr, who's one of the masters of transplant, come visit. And I've got like 5 slides from him. And this is a first report, though, the absolute first report of transplantation for E. Donald Thomas, won the Nobel Prize, 1957. Now, they did not know anything about HLA. They did not know anything about real T cells, but they put people together. And by the way, everybody died back then, but they were going to die anyways. 6 patients, different diseases. What they showed is you can actually isolate marrow and give marrow. And there was actually, for a few days, for a couple of weeks, you could have evidence that the marrow grew. So now you have to figure out the barriers. But the fact is, you can take cells from one person and give it to another. What they also started to do then, this became, something everyone to know, and we're starting to have inbred mice. And so people said, well, we could start to do experimental models in transplant. And what they did is they had newborn mice and they would give them cells from a different mouse strain. They used radiation. What they noticed is if they survived, the newborn mice, if they did survive, they often were runted. Their hair was falling out. They were smaller. And they called this secondary disease. They didn't know what it was. They just called it secondary disease. But later on, someone said, you know what? It's coming from the graft. That's graft versus host disease. And that was by Dr. Billingham. And this is what runt disease looks like. You can sort of see 2 normal mice on the left and 1 little small one with its hairs all shaggy. That's runt disease. That's secondary disease. That's graft versus host. So Billingham's triad was actually, which is, the first to report this, and he's the very first to call this. If you give cells from one person into the other, there must be immune cells that are competent. The second, the recipient must have something, we don't know what it is, they must have something that's a target of immunologic attack. And also, if you get it, it means the host can't fight back. That's the Billingham's triad, critical. And in a way, that's GVHD and graft versus and GVL. And so we know this complex, what we've learned over the whole time, that GVHD is a dysregulation of the immune system. It's very complex. It has donor T cells. It has host tissue. And if you have damaged host tissue, it's more likely to be inflammatory that will activate the donor cells. And now we know a lot about cytokines and inflammation. We learned a lot about sterile inflammation. And what we now know is we're starting to dissect GVHD. Turns out that we typically talk about graft versus host disease in a donor into a foreign host. So they just look different. I have leukemia, you're going to save my life and give me your bone marrow. Turns out, though, you're female, I'm male, there's going to be a reaction. There's going to be a rejection. What if we were identical twins? You had an identical twin. Well, an identical twin says you're genetically the same. But over time, over a lifetime, that person may have flu 3 times. This person may have CMV twice, once, and shingles. Their immune system's a little different. There's ways that you can manipulate and stimulate and create GVHD. And they called it autologous GVHD. A lot of the work came at Johns Hopkins. And it turns out, remember, cyclosporin is an immune suppressive agent. If I do an identical twin transplant, or I do an autologous transplant, so we heard about autologous transplant yesterday, I do an autologous transplant. If I give them cyclosporin for 3 months, as the immune system tries to recover after the auto transplant, it's disrupted. And you can induce a graft versus host response in the setting of autologous transplant. And we've been shown that over and over in acute leukemia, in myeloma, in breast cancer. So it's possible. And people, before many transplants, they were starting to do like, well, maybe if we're going to try and transplant a 65-year-old, because, 20 years ago, age 60 was considered the maximum, maybe I could give an autologous and give them cyclosporin afterward and create autologous graft versus host to help them live. So people started, they learning about GVHD, they learned things, they've learned a lot. And I can't do all of GVHD in 45 minutes or 50 minutes or whatever I'm going to do here. But I was going to say is, there's some common things. Who's at risk for getting GVHD? If you did a transplant and didn't give anybody any immune prophylaxis, they're going to get it unless it's a SCIDS child. Older age patients are more likely to get it than younger age patients. If there's an HLA mismatch, if the graft comes from someone who's been immunized multiple times. So a woman who's been pregnant 5 times, has had 5 children, they've been primed against the human species. You get her cells and put them in a recipient, they're more likely to react. It turns out it isn't just bone marrow. It turns out solid organ transplants, they've discovered, especially if there's a lot of immune cells. So a heart transplant is easy immunologically because the heart is not an immunologic organ. People are trying to do small bowel transplants or pancreas transplants where you get Peyer's patches with them. You can't get rid of all the lymphocytes. You get a GVHD response coming from there. Liver transplants, we reported, Laura Newell in my program reported 7 or 8 patients who've had liver transplants and had liver transplant associated passenger lymphocytes to cause GVHD. Most of the patients die because you got a liver, you have to immune suppress it, and then you go into flora GVHD. But some patients have survived. And finally, we know that just given unradiated blood in a immune deficient host, sometimes there's enough carrier lymphocytes to cause GVHD. We all know about how we stage it. Typically, classically, the first 100 days is when we see acute graft versus host. We see target organs, typically the liver, the skin, the GI tract. When we get into long term, the lung becomes a target, although some people there say there is an acute GVHD of the lung. There's a specific clinical grading system, and people are trying to evolve the grading systems. So we have learned one way, well, maybe this is a better way, maybe this is a better way. And so we are also refining how we stage. So let's going back. So Dr. Storb basically starting from E. Donald Thomas's original work in dog, they developed inbred dogs. And they basically said, what happens if we give and do transplants in the dog? So they have on the top, you have basically the equivalent of HLA, they're DLA identical litter mates. You do a transplant, it's like an identical twin, and they survive. It turns out if you take, let's say, a beagle and a shepherd, they may be DLA matched, but there's lots of other antigens. You do that, the disease is going to grow and the animal's going to die. What they ended up doing, or you're in the litter and it's not identical, it's like a haplo in the bottom. It turns out those animals do die. What he did though here is, for the first time, instead of dying within the first 2 weeks, they gave methotrexate for 100 days. And the way they did it, they gave it twice a week for 2 weeks and then once a week. That was the schedule. But what you end up doing is you can start to see some survival because the methotrexate, the single agent, is controlling GVHD. Then this was sort of a breakthrough. Ray Poles is from Wales in England. And Ray Poles is also probably most famous for developing high-dose melphalan, and like, the father of melphalan and for myeloma transplants. But Ray Poles also knew that there was a drug called cyclosporin, and the cyclosporin was being used in solid organ transplants and seemed to be immune suppressing people. And so basically, Ray Poles reported 43 years ago in Lancet, 23 patients, 21 with leukemia, 1 CML, 1 aplastic anemia, who got cyclosporin to try and immune suppress. What we see is there's 3 early deaths. And how did they die? There were some kidney issues. That was probably too much cyclosporin. There was skin rash. That was GVHD. So GVHD was there. But you could see that a number of patients lived. They lived a year. The maximum was 13 months, but they lived a year. Huge breakthrough. So what happened is, this is a slide from Reiner Storb. Ray Poles brought cyclosporin through customs, and it turns out it has to be, maintained, dissolved into an oil. It's lipid soluble. So this is Dr. Storb's experiment, is figuring out which of the various type of oils would be the best to dilute cyclosporin into, so you can actually maximize the benefit. And so again, I thank Dr. Storb for these slides, but it's a fun slide to think again. This is the history. This is where it came from. So we start to see then, we now know methotrexate by itself can do a little. We know that cyclosporin can do a little. So what happens? Again, now we're doing not identical twin DLA dogs so mismatched DLA. They all got lethal radiation. So we're going to see what happens. Can we get engraftment, and can we make can we overcome GVHD? You can see if there's no immune suppression, they're dead within 2 to 3 weeks. If, on the other hand, you gave cyclosporin alone, you could keep a small number of them. These are mismatched. These are like a haplo mismatch. You could get 10% of them would be alive maybe for 3 months. And, long methotrexate is the 2 times a week for 2 weeks, and then once a week to day 100. That also seemed to be, allowing a small number to stay alive. And so what happens, let's mix them, mix and match. Methotrexate and cyclosporin, first experiment, 17 dogs, and now they have at 6 months, a 30% survival. So they then looked at this in detail, and you could see this was interesting. They decided to make 6 different cohorts. And what was surprising is that there was a short group. They only did 4 doses of methotrexate plus the cyclosporin. And it turned out that that group actually had the longest survival. And so they said, that's sort of the answer. We need to start treating patients. And so the easiest patient population to treat is aplastic anemia, because aplastic anemia, you just have to get a graft. You don't have to worry about disease relapse. And so this is a study that Dr. Storr published in 1980 of using cyclosporin and now the basically 3 months worth of methotrexate, and you now have survivorship about 80%. So you're curing aplastic anemia. They then also did a comparison, a randomized trial in brother-sister transplants in AML or other malignancies. And they said, we're going to do single agent cyclosporin, single agent methotrexate. We know in the dogs, it seems that that's not good enough. It turns out that in humans, it may not be good enough, but they were able to cure some, but it was equivalent. You couldn't prove that single agent cyclosporin was better than single agent methotrexate given through day 100. When I started doing clinical transplant, we didn't have cyclosporin in Boston. So we were doing the long methotrexate as single therapy. So 1, 3, 6, 11, and then once a week through day 100. And so now, this was the breakthrough paper. I remember when this paper was published because we had to do everything possible to get our cyclosporin at our center. And what it was is saying, what if we gave, and you could see on the left, they're looking for grade 2 to 4 graft versus host. If you did single agent cyclosporin, there was still 60% graft versus host, but with the two drugs together, it was 30%. And the likelihood that, so the ability to control in the GVHD had a direct correlation with the ability to cure the patient, because you could see on the right, the overall survival was improved by patients who got combination methotrexate, cyclosporin, and over cyclosporin alone. Now that is 1986. I will say, just as a preface, there has been almost no significant progress on GVHD prophylaxis since calcineurin methotrexate until just recently. So for 40 years, this is now the standard. So, but I also want to point out it wasn't just Seattle's contribution. I'll sort of say what Boston did, but at Johns Hopkins, George Santos, another master of transplant, said, I'm going to use an immunosuppressive agent. Remember, drugs are drugs. Methotrexate, it's an anti-metabolite, kills lymphocytes. We use it in ALL. It's a good lymphocyte killing agent. It's a good GVHD agent. Cyclosporin, that paralyzes T cells. That's an immunosuppressive agent. Well, you know what? Cyclophosphamide, remember post-transplant cyclophosphamide? It's a big breakthrough. It comes out of Hopkins. Well, look where this started back in Johns Hopkins 40 years ago. They said, we know cyclophosphamide is a good immunosuppressive agent. Why don't we give it and use that as our way to transplant patients? And so what they did is they used the dose of 7.5 milligrams per kilogram, and they did it on day 1, 3, 5, 7, 4 times in the first week, and then 9. Sorry, so 5 times in the first 10 days, and then once a week through 100. So single agent cyclophosphamide is an acceptable regimen. And what they did is show that it was quite effective in GVHD prophylaxis. So I'm pointing out that what we think is new is not necessarily that new. We're using the same drugs all over again. At the same time, so we also know, let's do some more combinations. So Steve Foreman at City of Hope with Carl Bluma, they set up a transplant program. And what they did is they say, well, you know what? We also know in the same way, there's another drug that kills lymphocytes. It's prednisone. And we know methotrexate's there. Let's do methotrexate and prednisone, because we know, and let's do cyclosporin and prednisone and see what happens. And it turned out that, well, I'll just tell you that in this case, cyclosporin and prednisone was superior to methotrexate prednisone. So now it's another 2-drug therapy, just combining immune suppression. When I was in Boston, this is what on the left is the program that I was part of, which was, we said, what about T-cell depletion? They now have antibodies. And so we didn't have, like I said, we had antibodies before we had cyclosporin. And so we were doing antibody and complement depletion, and then immune toxin depletion. And what we do is CD5 is a pan T-cell marker. And what we found is we could cut the risk of GVHD down from 50 to 60% down to 20%. Rob Seufer, who's basically across the street from us at Dana-Farber, was doing CD6, another broad T-cell depleting agent. And what they showed is they found almost the exact risk of reduction of GVHD. But if you do pan T-cell depletion, we also learned something. That may not be the best idea either, because relapse goes up dramatically. So we can eliminate GVHD. Yes, we can 100% eliminate GVHD, but it doesn't mean you cure the patient, because you have patients now relapsing. You can see on the right, the likelihood of relapse after T-cell depletion was 70% by 2 to 3 years. And so, thus graft versus host. So I told you that Steve Foreman and Carl Bluma proved that cyclosporin prednisone 2-drug combination, well, it's a good regimen. How about if I do 3 drugs? So now I'm going to put methotrexate. I'm going to do cyclosporin, methotrexate, prednisone versus cyclosporin, prednisone. And as you could see, the probability of GVHD was far superior with control with 3-drug regimen. And importantly, in their experience, There was no statistically significant increase in relapse. So now we say, hey, you know what? 3-drug regimen may be what we want to do, and what we want to do is do cyclosporin, prednisone, and methotrexate. So Nelson Chow then went ahead and said, well, we now know triple drug better. It seems to be better than cyclosporin, prednisone. How about I do a randomized trial against 3-drug therapy against 2-drug therapy, but this time it's cyclosporin, methotrexate. So 3 versus 2. And what they're showing is, if you look, the acute GVH incidence was identical at 20%. The survival was identical. The relapse rate was identical. The chronic GVHD was identical. And basically, though, there was no statistically significant differences in the major outcomes. But if you did 2-drug regimen with methotrexate, your risk of pulmonary hemorrhage, diffuse alveolar hemorrhage, was 3-fold than using the 3-drug regimen. The conclusions of this study was, and your infection rate went up also somewhat with 3-drug over 2-drug. The conclusion of this study said you could do 3-drug, but you can't really say it's actually in the long run any better. Well, what we did at that time, though, is that particular 3-drug regimen had very high dose steroids for 4 months as a regimen. So we basically did a study at OHSU. Dr. Hayes Latin was our, junior faculty at the time. Now he's senior faculty. But we looked at the question about, let's do 3-drug regimen, but let's lower we don't need super high dose prednisone. We're prophylaxing. We don't have to use treatment doses of steroid. We can use lower dose because we want to test the 3-drug regimen. I will tell you that we had lower infection rate. We had excellent relapse-free survival. The time the GVHD was there, the overall survival was superior. These were high-risk patients. So for 10 years, 3-drug regimen was our standard at OHSU, but using a lower dose prednisone. And this was showing that where did we make a difference? So grade 1 with 3-drug without the dose escalation is the green. There was maybe more grade 1. There was probably less grade 2. It turned out the 3 and 4 were identical. If you're going to get bad GVHD, you're going to get bad GVHD. It's like your genetics say you're going to have a bad outcome. Where we found that if we made any difference by amplifying GVHD therapy, it was in the early phase of treatment when for that patient who's bordering, are they going to get grade 2 GVHD and then maybe go to grade 3? That's where we did better with our control. And we found that in survival, when we looked at 2-drug therapy, similar to what Dr. Foreman and Dr. Chow showed, our survival was identical with 2-drug and 3-drug. It was better than cyclosporin prednisone, but we definitely had less mucositis and less toxicity. Dr. Serpol and myself were talking about fungus. This was the early 2000s. We didn't have voriconazole then. We only had amphotericin. And that is still the issue, is we did have a lot of more fungal infection than we had now. So I take that you from 1975 to the year 2000. The year 2000 then says, you know what, we got better drugs now. I got the best drug out because there's a new immune suppression drug that's even better than cyclosporin. It's called tacrolimus. And so we're now doing unrelated transplants. And Richard Nash at the time was in Seattle. He's now in Colorado. Basically asked the question, methotrexate versus, and using the 2-drug regimen, methotrexate plus tacro versus cyclosporin and tacro. What they showed is there definitely was lower GVHD with tacrolimus. It was 50, this was unrelated transplants. It was about 55% versus 75%. However, it had absolutely no impact on long-term survival. So this was a phase 3 randomized trial looking for a label for, basically to say one drug is superior to the other. They did not reach their statistical endpoint. Now, what came out of this is a lot of places said, you know what, it's no difference. I'm staying with cyclosporin. In Europe, most countries just wouldn't take the label. The United States let tacrolimus be used. And I'll say it's easier on the patients. It doesn't stink when they ingest it. It's easier to measure and follow levels. And so most places over the years, for years, we just kept with cyclosporin. But over the last 15 years, most places in the country has moved to tacrolimus-based immunosuppression over cyclosporin, but not based on any data, based purely on preferential management. I'll skip that. So what have we learned since the year 2000? It's not that the field hasn't tried to learn more. They have continued to pursue. And so the first one was a study. So I mentioned the BMT-CTN. This is the United States collaborative activity that brings the country together to do multi-center trials in transplantation. And so one of the early trials, this is started 2004, 04, 02. Well, now we have tacrolimus methotrexate. That's what people are using. Well, sirolimus has now appeared, rapamycin. Well, what if can I substitute successfully sirolimus for methotrexate? Remember methotrexate, bad mucositis, higher risk of diffuse alveolar hemorrhage, doesn't happen with sirolimus. What they did is, this was for peripheral blood stem cell grafts only, myeloablative conditioning. And the results, though, basically showed at the end of the day, there was no advantage, no superior benefit of sirolimus and tacro over tacromethotrexate. So they had, it was not statistically significant. There may have been a slight reduction in grade 3-4 that was marginal for benefit. There was definitely less mucositis with sirolimus, but there was more TMA, thrombotic microangiopathy, so more endothelial activity. They also, for patients who got BUSI, myeloablative BUSI and sirolimus, those patients actually had a 50% of VOD rate. So tacrosirolimus is good for reduced intensity regimens or Cy-TBI, but not myeloablative BUSI. So you can see the high VOD rates at the bottom. So we learned something. What did we learn? It wasn't better, but it's an alternative. So if you have someone who has chronic active hepatitis and you need to transplant them, you're worried about liver, you would say, I want to get methotrexate. If on the other hand, you have someone who's had lots of pulmonary infections, cystic fibrosis, let's say, you may say, I don't want to give that person methotrexate. I can now use this as a substitute. So a lot of this is prophylaxis, and I told you that we were part of the studies in the 80s that said T-cell depletion could be done effectively, but most of those patients relapsed because they were so deep in, you didn't have anything to control. You depleted the T-cells, and what you did with the antibody depletion is you get what you get. Well, they're saying now, can we do something better with T-cell depletion, which is, and this was another study from the BMT-CTN. So Miltenyi, we hear about yesterday, for those who were here in the afternoon, we heard about, the Miltenyi and the Prodigy. Well, Miltenyi is a company that developed a cell sorter. So instead of doing antibody and complement, which just wipes out everything, and then you have no control, you can actually deplete your T cells on a column, and you could adjust the dose. So you can actually regulate the degree of T-cell depletion. And so the study was done, and you could see with almost no advanced GVHD, almost no chronic GVHD, this was done in an older patient population in CR1 and CR2, complete remission 1 and 2. It turns out the results showed us that when you look at survival, it looks pretty darn good for older patients with AML. It actually was higher if you only did it in CR1, because at CR2, the disease is already getting unstable and the relapse was too high. But either way, we now have another tool. The problem is that tool costs, it cost me $5,000 to charge, to purchase minimum, just the beads to do the selection. I think it's up to around 15,000 now. So a lot of people don't do that. Sloan Kettering, Memorial Sloan Kettering, New York City has made this approach their standard of care because, you know, they think, again, it's an effective way. They don't have long-term complications. Skip that one. I think that taking that idea then, and this is probably the beginning of post-transplant PSI. So can I selectively take out? I now know I can wipe out anything, all the T cells, and I now know I can deplete them and I can regulate how many T cells I give. How about, can I selectively deplete the cells that are going to cause GVHD? And so this was a study from John Barrett's group at the NIH, working with Ellen Vitetta, who developed an antibody toxin against IL-2 receptor. And so Scott Solomon, who's now at Emory, worked in that group. And it's a complicated slide, but let me just explain it. I'm the donor. I'll always be the recipient. I'll give myself the bad disease. And Diana over there is my donor. She's going to try and rescue me. So we know it's going to be a GVHD effect. So before we do the transplant, we take some of my cells out, irradiate them as an anti-stimulators, take some of her, we do the peripheral graft then, and take her cells and mix them together. And then what you'd end up doing in 48 hours, you come in with the antibody coupled to a toxin to kill anything expressing IL-2 receptor, the activated T cells. You wash it all out. So now I have her peripheral blood stem cells depleted of what we think is the mismatched alloreactive. And then I'm going to infuse that into people. And what it turned out is, you know, it was actually quite, given the patient population they were doing, it was very high risk patients. They actually had good survival, and you only need a cyclosporin for 3 months. The grade 3, 4 GVHD in a very high risk group is down to like 10% at highest. So a very effective thing, but now it's even more expensive because you're doing column selections, you're doing stimulations, you're doing you're doing extra collections. So, but it's 2005, we're making some progress. So in the last few minutes, I think I'm still going okay. I hope I haven't lost or bored everybody because this is history as opposed to where we are today. We got involved in a series of studies, and for over 10 years, I've done work with mesenchymal stromal cells, or MSCs. And I don't know if you've done any of that work here, but it started with Hillard Lazarus, who's another close friend and colleague of mine. We were part of 5 centers. So Case Western was the company that actually developed the way to purify and grow MSCs. They licensed the technology, and a company called Osiris bought it. Osiris has now sold it to Mesoblast, and Mesoblast has been trying to develop MSCs for 15 years in a clinical setting. But this is the first study coming out of Case Western and sponsored with Osiris, 5 centers. And the goal at the time is, so what's an MSC? The MSC is your microenvironment cell. So it's the cell that hematopoiesis grows on. They nurture it. It's like, you know, it's like mother-baby, you know, interactions. The cells help stem cells grow. That's a whole talk in itself about the biology. But so this was a goal of, could we enhance engraftment? Could we make engraftment better by doing a transplant and then adding MSCs? Well, what we showed was the MSCs didn't hurt anybody or but it also didn't seem to increase the rate of engraftment. But they only got cyclosporin and 3 days of methotrexate only. So a suboptimal GVHD prophylaxis, but it turned out the GVHD rates, you know, out of 46 patients, only 7 to 15% had grade 3, 4. And if we add 13, now we only have a 25% acute GVHD rate. So what are the MSCs doing? So that was then Frederick Frassoni. So he was part of one of the 5 centers with Andres Bacigalupo in Italy. They did a case match series of the patients treated in the first trial against the EBMT database, and it turned out that there was a statistically significant benefit of reduction of acute GVHD if you did a co-transplant with MSCs. So MSCs seem to be doing something. So when you do a co-transplant, it's safe, it does reduce GVHD, and it didn't like hurt this patient. So people, again, now it's another expensive product. You got to grow it for a few, in culture in a GMP facility. What did we learn? What else can we do? Well, it turned out this was sort of a breakthrough paper, a breakthrough study for mesenchymal stromal cells. Katerina LeBlanc with Ali Ringden's group, they do T-cell depleted haploidentical transplants. And they had a young man who's got a graft from his mom who was dying of steroid refractory GVHD. In this paper, they will say they've never had a patient survive steroid with their conditioning in their center with steroid refractory acute GVHD. And so what they did is, this was a young man, they did cyclosporin, they did steroids, they did PUVA, they did anti-TNF receptor antibody, they did IL-2 receptor antibody. Nothing would stop the GVHD. On the left, the bilirubin is in around 25. And when you look at the number of stools a day, it was often 10 to 15 diarrhea episodes a day. They had the mom come in, harvest basically 6 tablespoons equivalent of bone marrow, grow mesenchymal stromal cells, it's the microenvironment cells, and infuse them at 2 million per kilo, and the GVHD was eradicated. It went right down. You can see that was at day 60. So what do? They start to withdraw immune suppression because you don't have GVHD, no visible GVHD. And when they stopped the cyclosporin, whoops, the GVHD relapsed. And so they gave him a second dose of MSCs and got control. Now, what happened? Well, it turns out that MSCs are also like little magnets. They can circulate. They do want to go to the bone marrow, but they also go to sites of inflammation. And what they showed is, so remember, it's the son, it's an XY, and the mom's an XX. They can use chromosomal, painting to show that female MSCs were migrating to the GI tract. So what do the cells make? They make they make a ton of factors. They make a lot of immune factors to suppress, but they also make a lot of trophic factors that helps you repair your GI tissue. So keratinocyte growth factor is a big product of an MSC. And so it worked. So ultimately, immune sanctuary, they do have, these are the activity, they seem to be safe. They're not causing GVHD. They're not causing massive immune suppression to cause you to be relapse. And so what they started to say is, and by the way, in Europe and the United States, phase 2 trials looked really good. Here's the problem. Osiris owned them, they owned the license, and they went to do a clinical trial. Now, sometimes people are greedy. This was a case of greed because, as I said, as I showed you, if you stop immune suppression, you can relapse. They basically they did 2 trials in the United States, one for acute GVHD, new diagnosis, and one for uncontrollable GVHD. What they bet on, though, they bet on cure. The endpoint, the primary endpoint was you would have a response by day 28, within 1 month, and it would be sustained, and you wouldn't relapse. It turned out it's a durable, complete remission. Well, when we're doctors here at the bedside and we're treating a patient, and they've been on high-dose steroids and they're on high-dose other medicines, you start to, when they're doing better, you pull the medicines back. And if you relapse even 1 grade, you missed your point. So they did not hit, there was no statistically significant difference in the primary endpoint of durable CR. They did not build into the trial a scheduled immune suppression withdrawal. But if you look at, and Paul Martin and Paul Zabolix, one in pediatric, one adult, did sub-analyses and showed that in the sub-analyses, there was absolutely statistically significant benefit. So what's happened is this trial killed MSCs in the country for adults. Pediatrics have gone ahead and tried to do this. Dr. Nemechek has been a part of 2 studies that have been run through the FDA, but they've never done a randomized trial. The FDA just turned them down again for full approval. But MSC still has something. So we've learned a lot along the way. Like I said, I had worked on these for 10 years. And we had, I think, was a better sell. I would have skipped this. This was the trial that I ran where we actually have a precursor to the MSC called the MAPC, the multipotent adult progenitor cell. And what we could show is in a dose escalation for prophylaxis, we have 0 grade 3/4 and basically 1 patient with grade in a very large study, only 1 patient with advanced GVHD. So why is this thing, where has this gone? Well, the FDA approved it for registration. We went to England and the EMA approved this for registration. The company, though, said, we're going to do stroke instead. And they shut down their entire GVHD program because they said that they were going for 1 hit because there's some other benefit that maybe they could cut inflammation and help stroke. And that's another story. But this is a study sitting in the FDA has already approved it as a registrational study, has not have developed. So this is how would I design it today? I'd say you look at the biology. You look at, you talk about rheumatology, you ask someone who's got rheumatoid arthritis, you say you have it for life. If you've got lupus, you have it for life. The immune system doesn't go away. You have the GVHD, as I said right from the beginning, those cells are in you for life. You always have GVHD. So it's stupid to think that that was just that I can eradicate and it's guaranteed to go away. You just have to learn it's an immune system. You have to adopt it to the host. And this came from a paper of ours where we started dissecting the secretome. This is my last effort at being a scientist, where we were co-culturing the immune cells with MSCs and actually looking and identifying all of the different biologic pathways that are impacted by MSCs. I'm a big advocate of MSCs. The fact is nobody has learned how to, like we've learned from how to use cyclosporin and methotrexate, nobody's learned how to use MSCs as a drug. So on to the current days, literally 2-3 more slides. Pretty good. Got started a little late, but almost close on time. So what do we know? So MSCs, I said, failed in adult studies to reach the primary endpoint. Pediatric approval was just considered twice and just failed again this past, few months. We're going to still see it resurrect itself. It's still too good of a drug. JAK inhibitors, itacitinib is a JAK1 inhibitor. Ruxolitinib is a JAK1/2 inhibitor. Ruxolitinib has been now approved for steroid refractory GVHD, as well as for refractory chronic GVHD. Sometimes it's hard to use because it's more hard on the platelets. Itacitinib, the same company's trying to develop itacitinib because it doesn't have that same platelet, effect. And so we're seeing some studies come out, whether it's going to prove, whether it's worth it to the company to spend money on it, because itacitinib is, they have both drugs and, it costs a lot of money to run a trial. And right now the data doesn't look like it's any better. It may be a little safer, but it doesn't look it's so better that it's worth investing. The big one that for this year is BMT-CTN1703. This is post-transplant cyclophosphamide with MMF and tacrolimus versus TAC methotrexate, not in a mismatch setting, but in a matched setting, matched related, matched unrelated. And it was compared against TAC methotrexate. And the data was published in the New England Journal earlier this year. It was presented earlier this year. And it was in a way, it's the first big home run because it had a better GVHD relapse-free survival. However, did not have impact on overall survival, didn't impact relapse rates, but for ease, For ease of delivery, I think in the fact that there's a better GVHD control, we believe that if you follow this study, this is still early, you follow it to 5 years, by controlling the GVHD, you're probably going to have much better overall survival at 5 years. There's a lot of studies that the preliminary endpoint of overall survival is not met, but over time it's met. A lot of people think that that's going to come forth. Abatacept is now FDA approved. It's a co-stimulatory molecule, and when you activate T cells, it's beneficial. There's a study that was run in the United States by Leslie Keene that used abatacept in 5 of 6 and 6 of 6, or 7 of 8 and 8 of 8s. And it came out, for prophylaxis, it came out statistically significant as a benefit. It turned out there's really no benefit of 8 of 8 when you actually do by subset analysis. But if you have a 7 of 8 match, adding abatacept to TAC methotrexate looks like it makes a difference for your patient. ATG still is standard in the Europe. A few centers in the US still use it. In the US though, there's been a big randomized trial that showed that adding ATG to cyclosporin, to tacrolimus and methotrexate, actually there was worse outcomes, and it was related to higher relapse rate. May be linked to patients who got busulfan cytoxin, and CyTBI may be immune, but at the moment, ATG in the United States hasn't come forth. I put a role of MMF. MMF has become a really good drug for GVHD prophylaxis in the acute setting. In the chronic GVHD setting, we were part of a study, a seven-center study in the United States, first presentation of chronic GVHD, comparing, you may give tacrolimus and steroids. The steroids is this treatment of choice. Tacrolimus, steroids, and MMF. So again, 3 may be better than 2. Well, it turned out the chronic GVHD treatment was better with 3 over 2, but the survival was dropped by 20%. Because when you come ahead and do 2 things, if you add 3 drugs right up front, you increase the relapse risk. And the second thing is, if those 3 drugs didn't work, you didn't have anything. The GVHD was so advanced, the chronic GVHD, they all died of bad lungs, they died of GVHD. So the overall survival was hurt by using early MMF in the chronic GVHD setting. We try to avoid it. We use it for the acute. Other cell therapies, other things are coming. Mocovimod's a very interesting molecule. We're doing a research study with that right now. That's the sphingosine phosphate inhibitor. So multiple sclerosis is a disease, of immune cells attacking the brain and spinal cord. So this class of agents has been used to block migration. So it doesn't kill the lymphocytes, but it blocks trafficking of the lymphocytes. So this is a European company. So this is a 2nd or 3rd generation sphingosine, fingolimod. I think it's the 1st generation. This is 2nd or 3rd generations, sphingosine S1P inhibitor. It's easier to say it that way. Their theory is it's going to do 2 things. One, it's going to keep T cells in the bone marrow. They're not going to be able to migrate, so you're not going to get GVHD of the gut. Their data seem to show that in animals, but what's more is by keeping T cells in the bone marrow, for acute leukemia, you're actually going to augment the graft versus leukemia effect. So their primary endpoint is leukemia control, not GVHD control. But we're part of that study, and we'll see what happens. So I said, what's missing? What's next? Well, I just learned about something that I somehow missed. There's some company, some group somewhere in the world has been playing around with mixing and matching with post-transplant Cy. And so there's a study here by Kunichiwa from using post-transplant Cy with MMF and ATG before the transplant. And, the data look pretty darn good. I don't know who thought that up, but they're pretty smart. I want to give them a tip my hat. It was done here. That's you guys. So I'm just saying, I think that is a very unique study, and I think it does, because by day 35, you're off all immune suppression. So immunoconstitution could be better. You know, the long-term data look pretty darn good, but time will tell. So thank you all. Thanks for having me. I enjoy what I do. I enjoy building collaborations and building networks and meeting new people. So thanks.
Thank you very much, Chad.